I would like to discuss the following objectives. First, the non-inferiority design. When should I use it? Which patients are analyzed? Which statistical test should I use? And particularly in the end about subgroups and interaction. Let's start with the non-inferiority trial. The standard is the superiority trial. The aim of a superiority trial is whether new treatment is better than the current standard treatment. And in comparison, the non-inferiority trial tests whether new treatment is not worse than the current treatment. It tests if it is not worse, and this is measured by more than a pre-specified tolerable amount, that is the non-inferiority margin. And the new treatment may have some advantages other than improved efficacy, so you can use a non-inferiority design. Therefore, it should have some other advantages. This could be, for example, the ease of administration, greater availability, it may be less invasive, it may have few adverse effects, or it may have reduced costs. Basil already discussed this yesterday. For testing of non-inferiority, an on-treatment analysis should be used, as the intention to treat analysis may dilute an underlying superior effect of the old treatment. So this is one of the specific situations when you should use the on-treatment analysis not to dilute any effect, any underlying effect. The limitations of a non-inferiority trial: it increases the complexity of the study design and analysis. It usually requires a larger sample size, and it may be affected by the artificial definition of a non-inferiority margin influencing power and significance of results. There are a lot of guidelines who you should define this margin of non-inferiority. Here we see how this works. We have here one, which means that both treatments, the new treatment and the control, are equal, and then we have a defined margin for non-inferiority. For example, here we see an effect, a superior effect, which means that the confidence of interval does not include 1, does also not include the margin for non-inferiority. Here we have an example of non-inferiority. Here the confidence interval does include 1, that's fine, but it does not include this margin for non-inferiority. However, if we define this margin for non-inferiority differently, for example, we put it here, suddenly the same data become inconclusive. So it really depends on the definition of this margin of non-inferiority, how the results are analyzed. Let's look at the sample size considerations for non-inferiority trial. For example, here in the first row, we have control and experimental treatment. We think they will have the same effect, a 60% success rate. We have a non-inferiority margin of 5%, we have a power of 80%, and we need a group size of 1,188 patients. If we think that the new treatment is slightly better with 62%, then our sample size drops from 1,200 to 600, so almost a half. If we think that the new treatment is slightly worse, we suddenly need much more patients, so we need more than 3,000 patients. So this is very important to think, do we really think they are the same, have the same effect? Here on the fourth row, if we widen the margin for non-inferiority from 5 to 8%, so slightly widening of the margin, we suddenly need less patients. We do not need 1,200, but 450 about. And if we go again for a lower margin of non-inferiority with the same sample size, we lose a lot of power from 80% to 46% of power with the same sample size. And this power, once again, is the likelihood that we really get a significant result. So sample size calculation is very complex and very important in non-inferiority trials. Here we have an example. It's a real-life trial which compared dabigatran to warfarin. There were 2 doses of dabigatran tested. And first here we see the non-inferiority p-value, and we see both confidence intervals do not include the non-inferiority margin, which was defined as 1.46. So both are highly significant with regard to non-inferiority. However, with superiority, we have different results. Here we see that the dabigatran 110 milligram dose was not superior, it includes 1, but the higher dose was significant. There were different definitions of the non-inferiority margins in the NOAC trials between 1.38 and 1.46. But obviously we had enough space, and I don't think that this influenced the results if you look at the difference between the non-inferiority margin and the confidence intervals. And only if non-inferiority has been fulfilled, also superiority has been tested. That's for avoidance of type 1 error, so we don't do too much testing. What was the rationale to use a non-inferiority trial in the case of NOAC trials? There was a perceived advantage of the new therapy. This was the lack of laboratory monitoring and the use of a fixed dose with NOAC, so it was agreed that a non-inferiority design makes sense. But you should always ask the question, does it really make sense? We move to the patients group, which are analyzed. We have two different possibilities to analyze. We already discussed this yesterday. This is the intention to treat analysis. This includes all patient times according to treatment allocation, regardless if the patient really took the treatment at the time or not. In comparison, the on-treatment analysis considers only the time periods when the allocated treatment has been taken. The intention to treat analysis is the primary analysis for superiority of randomized controlled trials. It prevents bias due to drug discontinuation and loss to follow-up. So this is the safest way of analysis, and this is the gold standard of analysis of RCTs for superiority. And the effect of the drug may be diluted because the patient didn't take the drug, but may reflect a realistic effect under operational conditions. So it measures effectiveness. And on the other side, with the on-treatment analysis, this is prone to bias. So the question is why a patient didn't take the drug. Was it related to the drug? Why they discontinued the drug? But it shows the biologic effect. It measures the efficacy, so the effect under ideal conditions. Here we have an example. That's the ROCKET-AF trial where rivaroxaban was compared to warfarin. If we look here, we have the intention to treat population. That's 7,081 patients, 7,090 patients, and compared the as treated, so that's the on-treatment population, there's only a small loss of patients. Here we have 20 patients less, here we have only 8 patients less. However, if you look at the event, at the number of events, we have a great loss of events. In the rivaroxaban group, we lost 30% of events when we only analyzed on treatment compared to intention to treat. In the warfarin group, we lost 22% of all events due to the analysis only of on-treatment patients and on-treatment patient times. So the question was only why there was so high discontinuation rate, and also was the difference between 22 and 30%, so was some differences in the number of lost events. So there may be a discontinuation just due to chance, and there may be also a therapy-related loss of events. There are different reasons. By chance means that a complex study protocol caused a high dropout rate and therefore a significant number of events after drug discontinuation. Particularly this was, as we discussed yesterday, a double dummy study, so it was very complex, the study design. Of course, there was a high dropout cohort. And the drug treatment may not have been so well monitored after study drug discontinuation, so this may also have caused a higher event rate after discontinuation. There may also have been therapy-related, and that's the thing which we are more afraid of, because they are therapy-related and may cause a bias. The study drug may have been discontinued because the patient already had some side effects, possibly related to the study drugs, such as small drop in hemoglobin or a positive test for blood in the stool or something else, and decided to discontinue. Or the patient with the study drug with a shorter half-life may have been less well protected in the transition period. There's another example. Here we see the study flow from the ARISTOTLE trial. This was comparing bixaban compared to warfarin. If you look here, they assessed almost 21,000 patients. They randomized 18,000 patients. And if we look, we see the same number of patients allocated to a treatment were also analyzed. So they used the gold standard in intention to treat analysis. But if you look here on the follow-up, we see some patients were lost. And we have always to be critical about this patient, what we know about this patient. For example, there are some patients with vital status unknown at the end of the study. And if you look, for some patients, we know why they didn't have a vital status at the end of the study, because, for example, they withdrew the consent. But there were some patients here called other patients. There were 53 patients with unknown vital status of unknown cause in the apixaban group, and 59 patients with unknown vital status of unknown cause in the warfarin group. So the question is, may this have influenced the results? And if we look, for example, at mortality, so death from any cause, we see here the results, and there was a benefit for the apixaban group. So the question was, how may these patients have influenced the results? If we look at the event rate and think they have the same event rate, then we would need to add 4 patients in each group, so not much would change. If we think all patients have died who have an unknown vital status of unknown origin, also not so much may have changed. We have here 53 more patients and 59 more patients in the warfarin group. However, the only thing which really may affect the results is if we have a differential difference between the groups in case of mortality. So, for example, in this group, all 53 patients died and none of these died. However, we don't have any indication for this, and the numbers are very similar. But still, we have to be aware, also it's a very low number of patients which we miss. They may influence the results if there was something happening differently in these patients between the groups. Let's go to the statistical tests. You need some statistical tests for baseline characteristic with the question, are they equally distributed? You just use the normal tests used according to the distribution of the data. So if you have normally distributed or not normally distributed data. For the outcome, you have to think what outcome do you have. If you have a binary outcome, so 0 or 1, you need logistic regression. If you have a continuous outcome like blood pressure differences, you need an analysis of covariance. And you have a time to event analysis, you usually use the Cox proportional hazards model. The most commonly used analysis is the survival analysis. You can use this Cox proportional hazard models, or you can use Kaplan-Meier curves. What do I need to know from each participant to make a survival analysis? First thing, I need to know when the patient is enrolled, and the second thing, I need to know the time of the endpoint, or if the patient does not have an endpoint, the time of last contact, which then is the sensor time. So if a patient does not have any endpoint, we are happy, but then we still need to know when he has been contacted the last time. Do I need a multivariable model in case of randomized controlled trial? No, we don't need, because usually we need this multivariable model to adjust for confounders, but in a randomized controlled trial, due to randomization, already the confounders are balanced. So we just need a univariate analysis. A topic which often is discussed are interims analysis. A trial is stopped early if an interims analysis reveals already large differences between treatment groups. A certain safety boundary margin is defined, and if the effect is outside this margin, then the safety committee usually stops the study. The aim of interims analysis is to reduce the exposure of participants to inferior treatment, also to save time and resources. However, if you have a premature end of a study, this may limit the power of the study and also weakens the conclusion. And you also have to take care about multiple testing, so if you do a lot of testing, you're also prone to false positive results. Here we see an example. That's the MADITT II trial, which investigated the preventive effect of an ICT for prevention of sudden cardiac death. And we see here these boundaries, and we see the line here in the study developing. And here, first time in November 2001, the boundary was crossed, so there was a clear sign that the ICT was beneficial. Still, the committee waited until January 2002 and waited if the trend really goes in the same direction, and it did. And so they finally, in January 2002, then closed out and stopped the study early. Finally, let's look at subgroups and interaction. A subgroup analysis is any evaluation of a treatment effect for a specific endpoint in a subgroup of patients defined by baseline characteristics. The aim is to extract as much information as possible to investigate the consistency of the trial conclusions among different subpopulations, but also to identify patient subgroups who may particularly benefit from a treatment. However, there's a big disadvantage. It may lead to overstated and misleading results, so we have to be very careful about the interpretation of subgroups. In a subgroup analysis, both may happen, a type 1 and a type 2 error. Type 1 error means they are false positive, the results. So when you do multiple testing, because you have multiple subgroup analysis, when you use a p-value level of 0.05, you have a chance of 1 to 20 that you get a false positive result. But you also have the chance of a type 2 error, which means that you see false negative results. So there would be a result, so a significant difference between the groups, but the sample size is too small, and particularly the sample size of the subgroups. You should always pre-specify your subgroup analysis, which means that a pre-specified subgroup analysis is one that is planned and documented before any examination of the data, preferable in the study protocol. And post-hoc analyses are particularly prone to multiple testing, and they're particular concern because it's often unclear how many were undertaken and whether some were motivated by inspection of the data. However, for both, they are subject to inflated false positive rates, so we have to be very careful. What we want to investigate is effect modifications. We want to see if there's a qualitative variation of the effect between subgroups, which is called heterogeneity or effect modification. And this is typically analyzed with a test of interaction, where interaction term is used in the analysis. And this presence or absence of any interaction is specific to the measure of the treatment effect. So if I have an interaction, for example, for mortality, this does not mean that I have an interaction for a recurrent myocardial infarction, for example. There are several restrictions. A common mistake is that we just look at the subgroup, see a significant result in one subgroup and not in the other, and think there's a difference. But we always should rely on this interaction term and then the P for interaction. And as we already discussed, when multiple subgroups are analyzed, we have a risk for type 1 errors or false positive findings, and also many trials lack the power to detect heterogeneity in treatment, which is a type 2 error. So we have really the chance of both types of error to occur. Here we have an example. That's the ENGAGE AF-TIMI 48 study, which compared edoxaban to warfarin. And here we see the forest plot, which we already discussed yesterday. In the beginning, we see the overall effect, and then we see many subgroup analyses for many baseline characteristics, such as age, sex, region, race, AF type. And we should look at this interaction, p-value for interaction, and we see here we have borderline significance for the AF type, for example. So this could be really a difference in the effect. On the other side, you may look here, for example, for hypertension and say, okay, here in this subgroup, it seems that patients with hypertension have a benefit, but patients without hypertension does not have a benefit. However, if you look at the p-value for interaction, you see it's not significant, and the main reason is because the group with no hypertension was very small, and there was a wide overlap of the confidence intervals. So you cannot be sure that there's really effect modification for hypertension. Again, if we look at the significant p-values for interaction, we see VKA naive patients may have a particular benefit here, for example, or here. And here we see the smallest p-value for interaction was for amiodarone use. So we see here the group with amiodarone use had a higher benefit or larger benefit than the other group, and there was almost no overlap of the confidence intervals. So this was really highly significant interaction. So we should always look at the forest plots and also look at the p-values for interaction to make any conclusions. So we are at the end. My take-home message is the rationale for a non-inferiority trial has to be well justified. Intention to treat is the gold standard in the analysis of a randomized controlled trial, and subgroup analyses are prone to type 1 and type 2 errors, and they may generate new hypotheses only. Thank you for your attention.